the objectives of this part, and this is going to be the objectives of the upcoming parts as well. We will talk about the mechanism of action for the drug, and then the mechanism of drug resistance, some basic principles, and some drug toxicity. As we did earlier this morning, I liked to give a little bit of history, and here I would like to mention Dr. Gerard Domag. He received a Nobel Prize in Physiology of Medicine in 1939. So what he did, he really discovered Prontosil. At the time, he was working with colleagues at Bayer. Now Bayer is a pharma, but at the time it was a dye industry. And he discovered that Prontosil is a beautiful antimicrobial, and this is important because we were done with World War I and World War II was coming up, and we needed antimicrobials that kill bacteria such as strep and staph in wounded soldiers. It turned out that this azo link here is very important, and as you will see in the next slide, by just cutting the azo link here, you get actually the active moiety, which is sulfanilamide or para-aminobenzene sulfonamide. So this breakage of the azo link happens by reduction or metabolism. Of course, Domag and his colleagues performed a lot of experiments that we now take for granted. Let's see what kind of experiments he did, and let's have a clicker question on that. Let's try to guess what kind of results he actually got in order to prove that you really need to cut this link to get the active moiety, which is sulfanilamide. So here's the clicker question. Think about it a little bit. Well, the answer is C. So it turned out that Prontosil is active in vivo and not in vitro. And this makes sense from what we just explained. And here are the sets of results that were shown at the time. Sulfanilamide is active in vitro as well as in vivo, whereas Prontosil is not active in vitro or culture. And sulfanilamide can be produced from Prontosil by tissues because you need metabolic activation. Patients or lab animal receiving Prontosil or sulfonilamides excrete only sulfanilamide. And those are very important results for sulfonamides. This slide looks busy, but it's okay because there's a point that I want to make. So we started with Prontosil and now we have sulfanilamide, and it turns out that sulfanilamide actually was a very useful starting point to synthesize other drugs of different classes. For instance, we also have several sulfa antibacterial agents, and we also have some antivirals. We have sulfones for acid-fast infections such as tuberculosis. We have some antithyroid agents. We have oral antidiabetics, in this case sulfonylureas. We also have probenecid, you probably already took it, that stimulates uric acid excretion. And we also have a bunch of diuretics such as thiazides and furosemide. Why is this important? The point that I want to make is that sulfanilamide is associated with hypersensitivity, with allergy. And when you go to the hospital, one of the questions you're going to ask your patients is the following: are you allergic to sulfanilamide? Well, the patient will tell you, I have no idea, I've never received sulfanilamide before. But then there is this cross allergy among all of those different classes. Well, you would tell your patient, I know you're diabetic. Have you ever received a sulfonylurea? And if the patient tells you, well, yes, I tried sulfonylureas once and turned out to be very allergic. I had a severe reaction. Well, in this case, there's a good chance that your patient will also be allergic to sulfanilamide, will also be allergic to thiazides, furosemides, among others. So this slide, the point here is this cross allergy among the different classes of drugs. We already now know that this is how sulfanilamide looks like, and the important part that is giving the antimicrobial activity of this drug is the sulfonamide here that is circled in red. And we have different drugs in the same class, such as sulfadiazine, sulfamethoxazole, sulfisoxazole. Here the changes are on the N here, the position number 1, and this is giving the drug different pharmacokinetic properties, different potency, and sometimes the spectrum of activity slightly changes. Concerning the mechanism of action, well, sulfanilamide is very much similar to para-aminobenzoic acid, and this is important in folate synthesis to ultimately end up with a nucleic acid synthesis. You may remember earlier this morning we talked about the mechanisms of drugs. In one of the slides, the sulfonamides were classified among the drugs that inhibit DNA synthesis or DNA integrity. Here we're really inhibiting DNA synthesis. The mechanism is a competitive inhibition of the enzyme dihydropteroate synthase. The competition is with para-aminobenzoic acid. So we have pteridine and para-aminobenzoic acid, and with the enzyme dihydropteroate synthase, you end up with dihydropteroic acid, ultimately with nucleotide synthesis. So as you can see here on the right, sulfonamides compete with para-aminobenzoic acid on the enzyme dihydropteroate synthase, and hence this pathway is stopped. The beautiful thing about this is selective toxicity that we talked about earlier this morning. It turned out that us eukaryotes, we really don't have dihydropteroate synthase, as we take folic acid from the diet and it goes into dihydrofolic acid, tetrahydrofolic acid, and then nucleotide synthesis. Whereas for bacteria, they cannot take folic acid from the environment, they need to synthesize it, and hence the selective toxicity. Please note that sulfonamides have a bacteriostatic effect, and we said today why is it important to know why a certain drug is bacteriostatic, another is bactericidal. This is very clinically relevant. For every drug class, you're going to see a slide in my PowerPoint slides about resistance. There are many ways of having resistance, but what you will see listed in my slide are the most common or the ones that were experimentally proven for a specific antimicrobial. For instance, for sulfonamides, we could have either a lower affinity by the enzyme, we could have a decreased bacterial permeability or an active efflux of the drug, we could have the development of an alternative metabolic pathway for the synthesis of dihydrofolate, and also we can have increased production of para-aminobenzoic acid by the bacterium. All of this will lead to resistance. Selective toxicity, I already mentioned that microbes, they cannot take folic acid from the diet, and they need para-aminobenzoic acid and the enzyme in order to synthesize nucleotides. You mentioned that already. Toxicity, of course, there are several toxicities, but what we mention here are the most common or the most serious. So we have photosensitivity, so you want to make sure that if you prescribe your patient a sulfonamide, you want to tell your patient not to go and sit in the sun or to put sunscreen. One problem that could happen is renal damage because of sulfonamide crystals deposition, so you want to tell your patient to drink a lot of water to stay hydrated. But sometimes you may want to alkalinize the urine because that would dissolve the crystals. And another thing that we already mentioned is allergy. You may have idiosyncratic reactions, allergy. People who have a G6PD deficiency are more prone to have hemolysis, and you may have fever, skin rash, joint pain, lymphadenopathy, all the way to Stevens-Johnson syndrome. And this will happen even more in patients who are slow acetylators because the NAT enzyme will not metabolize the drug. And if you remember from the busy slide that we saw together, sulfonamide, from them we got several classes, and one of them were actually the antituberculosis treatments, and you remember the NAT enzyme involvement in the metabolism of those drugs. Another problem with sulfonamides is that it competes on albumin binding with bilirubin, so it may kick out bilirubin, and hence you would have more free bilirubin in the blood. And this is relevant in newborns because newborns do not have a very good blood-brain barrier yet, so bilirubin may cross the blood-brain barrier and lead to a disease called kernicterus in the newborn, which is very serious. So age is important. Those drugs cannot be given to newborn. Also, they cannot be given to pregnant women, and they also are found in the milk, so we do not want to give them to a woman who is lactating, or if she takes this drug, she definitely should not be lactating. So this is important. Sulfonamides were the first ever drugs used, antimicrobials used. We still use them. At the time they were used for a lot of things, but now we have better drugs. We tend to keep them for urinary tract infections due to gram-negative bacteria. Now in the Lebanese market, you don't see a sulfonamide alone. You see sulfonamides as combined with another antifolate. For instance, we have Bactrim in Lebanon, or Septra in the US, and that is trimethoprim and sulfamethoxazole. You don't really need to remember the names, but let's talk about the mechanism of action of trimethoprim. Or another drug could be pyrimethamine, so you usually find them in combinations, sulfonamide plus a diaminopyrimidine antifolate. So here's the same pathway that we saw before. We already know the mechanism of action of the sulfonamides, and now we have trimethoprim here. Trimethoprim competitively inhibits dihydrofolate reductase. It is competing with tetrahydrofolic acid. When we have sulfa plus trimethoprim together, we have a synergistic effect, and the antimicrobial may also become bactericidal. Now you would ask yourself, okay, but where is the selective toxicity here? I probably convinced you why sulfamethoxazole is selectively toxic to the bacteria, because we humans do not have dihydropteroate synthase. Well, the point here is that we do have dihydrofolate reductase, but it is a little bit different from that of the bacteria, and trimethoprim competitively inhibits the bacterial one much more than the host one. And this is what I just mentioned concerning selective toxicity. Advantages of the combination: there's a synergistic effect. We may end up with a bactericidal activity. There's a broadened spectrum of activity, and we mentioned that earlier today. When we combine drugs, do we have more toxicity or less toxicity? Well, in this case, when we combine them, because of the synergism, we're actually giving lower doses of both, so we may have lower toxicity from each one of them. I don't know if you took the cytotoxic drugs for cancer yet, but methotrexate is actually an antifolate cancer drug. It has a similar mechanism of action like trimethoprim, but as you can see here, the concentration that is needed for methotrexate to inhibit the human enzyme is much lower than that needed for trimethoprim, and this is why methotrexate is used as a cytotoxic drug for cancer, whereas trimethoprim is used as an antibacterial drug. Of course, methotrexate will kill the bacteria, but we don't want to use it as an antibacterial because it is not selectively toxic to bacteria. Concerning resistance to trimethoprim, the mechanisms that are published are overproduction of the enzyme or reduced susceptibility of the enzyme to trimethoprim. Concerning toxicity, it's quite rare. We may have rash, nausea, and vomiting. And by the way, for all antimicrobials, if you have no idea what toxicity or you didn't memorize anything, well, if you choose nausea and vomiting, 90% of the times you are correct. And how about we think of this question? Well, the answer in this case is megaloblastic anemia. You did not take the anemias yet, but let's discuss. The issue here is folate deficiency, right? So it's definitely not C, not iron deficiency. Iron deficiency is irrelevant in this case. You will learn later that when we have iron deficiency anemia, the anemia is going to look microcytic, meaning that the red blood cell size is small. And you will learn later that when we have folic acid deficiency or folate deficiency, you would end up with a megaloblastic anemia, meaning that the red blood cells are large. And this is why in nutritionally deprived patients such as alcoholics, maybe pregnant women, if they receive trimethoprim, you would have a risk of megaloblastic anemia.